Welcome back. Last time we talked about the most common disease of the pericardium, acute pericarditis. In this sketch, we'll continue on where we left off in part 1 by covering the other pericardial diseases you'll need to know: pericardial effusion, cardiac tamponade, and constrictive pericarditis. If you've completed our sketchy path course, you know what's coming. We're heading back to the concert venue. Only we're not dealing with jangly country guitar music this time. Nope, it's time to bleed metal. At Sketchy, you're no plebe. We're giving you an all access pass. So let's head backstage and kick off our first disease: pericardial effusion. As you might have heard from our last sketch, the pericardial space normally contains a small amount of fluid. A pericardial effusion, then, is just too much of a good thing. When there's more fluid than normal in the pericardial space, we call it a pericardial effusion. Pericardial effusion can develop in patients with virtually any condition that affects the pericardium, but it doesn't have to occur with any pericardial disease. Just like this happy backstage fan, if your patient has a pericardial effusion, they probably don't know it. The normal pericardium can stretch to accommodate additional fluid, to a point. How much fluid the pericardium can tolerate is largely dependent on how quickly the effusion develops. Subacute or chronic effusions allow the pericardium time to stretch to accommodate all that extra fluid, so patients usually won't see symptoms until a big effusion develops. With acute pericardial effusions, however, you don't have luxury of time, which means symptoms will manifest despite a much smaller volume of fluid, hence the speed kills t-shirt. So metal. Regardless of how quickly an effusion develops, eventually the intrapericardial pressure will increase. And when it's high enough to impede cardiac function, cardiac tamponade develops. We'll get to tamponade later on in this sketch. The bottom line is, unless patients present with symptoms and signs of cardiac dysfunction due to cardiac tamponade, you'll usually only discover a pericardial effusion incidentally during evaluation for other cardiopulmonary diseases. While most patients without a hemodynamically significant pericardial effusion won't have symptoms specific to the effusion, they'll probably have symptoms related to the underlying etiology. Fortunately, the causes of pericardial effusion are virtually identical to those causing acute pericarditis, represented by our familiar friend from part 1, the red-lined guitar case. So let's do a brief recap. These causes include mediastinal radiation, recent myocardial infarction, uremia, and collagen vascular diseases such as systemic lupus erythematosus. A few other conditions are unique in that they tend to primarily cause pericardial effusions rather than pericarditis. First, mediastinal malignancies, especially metastatic ones, can often cause pericardial effusion without overt pericarditis. At Sketchy, cancer is represented by our recurring symbol, the cancer crab-shaped electric guitar. A must for any self-respecting metal band. Next, cardiothoracic surgery, including relatively minor diagnostic or interventional cardiac procedures, often cause pericardial effusions. That's why this bass guitar looks like a rusty scalpel. I hope you don't cut yourself playing that thing, band guy. But if you do, I expect you to bleed metal. Finally, in certain situations, such as a chest wall trauma from a car accident or a type A aortic dissection, blood can seep into the pericardium, creating a specific type of pericardial effusion called hemopericardium. As we mentioned earlier, isolated pericardial effusions are often picked up incidentally instead of presenting with their own unique symptoms. Let's take a look at the findings you should watch out for to raise your suspicion for pericardial effusion. On exam, you may notice distant or muffled heart sounds, represented by the heart-shaped earmuffs on this roadie. Just like her, you'll have a hard time palpating the PMI in a patient with pericardial effusion, since the extra fluid dampens the PMI and makes it soft or non-palpable. Classically on ECG, you'll see the QRS amplitude change or even switch axis with every beat, kind of like the alternating levels on this sound mixer. This finding, known as electrical alternans, results from the heart swinging around within the fluid-filled pericardial sac and is typically only seen with large pericardial effusions. Electrical alternans is specific but not sensitive for pericardial effusion. So don't rule out the disease if you don't see the characteristic finding on ECG. If you look closely, you might also notice low QRS voltages, almost as if someone turned the knob all the way down on your patient's ECG. Come on, dude, there's an 11 on the knob for a reason. Similar to muffled heart sounds and non-palpable PMI, low QRS voltages are seen because all that fluid forms a barrier between the heart and the ECG leads. Most of the time, a chest X-ray in a patient with pericardial effusion will be unremarkable. However, in large pericardial effusions, the chest x ray, represented by our recurring sketchy symbol, the skull and X bones t shirt, may show cardiomegaly and a water bottle silhouette. Hence the red water bottle in the hand of our roadie. Gotta stay hydrated, cardiomegaly style. All of those findings are nice and good, but if you're looking for a pericardial effusion, there's really only one tool to use: a transthoracic echocardiogram, represented by our recurring sketchy symbol, the heart shaped megaphone, is the test of choice for diagnosing a pericardial effusion. Not only does it reveal the effusion itself, the echo can also evaluate whether the pericardial effusion is affecting cardiac function. Let's sum up the clinical presentation of a pericardial effusion in a sample assessment statement. Perry Effis is a 42-year-old man who presents for his annual physical. He states that he had an upper respiratory infection that resolved a week ago. Otherwise, he has no past medical history and takes no medications. Physical exam is significant for muffled heart sounds and a difficult to palpate PMI. ECG is significant for low QRS voltages throughout. Based on these findings, the most likely diagnosis is a pericardial effusion secondary to acute viral pericarditis. Pat yourself on the back. You've diagnosed a pericardial effusion. No, seriously, that's pretty much all you have to do. Most cases of pericardial effusion are self-limited and require no treatment. Don't just forget about the patient, though. You must monitor the patient for signs of hemodynamic instability, as this indicates the effusion is getting too big and tamping down on the heart's ability to pump blood. Speaking of tamping down, that brings us to our next pericardial disease: cardiac tamponade. Spent a hot minute on that segue, so I hope you all are happy. Anywho, we've alluded to cardiac tamponade, but it occurs when intrapericardial pressure becomes high enough to impede venous return, cardiac filling, and stroke volume, leading to decreased cardiac output. At Sketchy, cardiac tamponade is represented by this hand squeezing that heart. So metal. As we mentioned earlier, cardiac tamponade is much more likely to occur with acute pericardial effusions in contrast to subacute or chronic ones, because the pericardial sac doesn't have the luxury of time to stretch and accommodate the extra fluid. Hence our recurring "speed kills" tour logo. Oof, watch out for that falling stage light, dude. That's not metal, that's just dangerous. Let this downed crew guy be a lesson to you all. Dyspnea, represented by our recurring sketchy symbol, the puff of air he's blowing out, and chest discomfort, represented by the light hitting him in the chest, are the most common presenting symptoms in cardiac tamponade. Remember these causes of pericardial effusion? Good. Since pericardial effusion is by far the most common cause of cardiac tamponade, you should also investigate these causes when dealing with a patient presenting with suspected tamponade. The heart of your diagnosis, heart, get it? So funny, I could die. Anyway, the heart of your diagnosis of cardiac tamponade lies not in the history, but in the objective findings that you'll see in your patient. Let's cover 3 specific physical exam findings first. First, hypotension is a very common vital sign abnormality in patients with cardiac tamponade. At Sketchy, hypotension is represented by our recurring symbol, the fainting lead singer with that BP cuff on his arm. The low blood pressure reflects decreased cardiac output due to the heart's inability to expand against that high intrapericardial pressure. Decreased cardiac output is driven by a drop in stroke volume, which manifests as a narrow pulse pressure. Second, elevated JVP with distended neck veins is also frequently seen. Distended neck veins, represented by the 2 big blue necks on that double guitar, reflect impaired diastolic relaxation and filling of the heart as it gets squeezed by the pericardium. Third, muffled heart sounds are sometimes heard in cardiac tamponade. As we mentioned before, muffled heart sounds, represented by the heart-shaped earmuffs on that metal drummer, reflect the dampening of sound by the pericardial effusion surrounding the heart. Put these 3 rockers together and what do you get? Beck's Triad, coming to a hardcore dive bar near you. While Beck's Triad is only seen in a minority of patients with cardiac tamponade, it is frequently tested. In addition to Beck's Triad, other exam findings can be seen as well. Tachycardia, represented by our recurring sketchy symbol, the heart clock, is seen in almost all patients with cardiac tamponade. Tachycardia will manifest early on, even before the onset of hypotension, as it's the body's way of maintaining cardiac output in the setting of decreased stroke volume. Ooh, dang. Love the shirt, buddy. Descent is so metal. Anywho, let his Joker-esque statement remind you that in cardiac tamponade, the JVP waveform will demonstrate absent Y descent, reflecting an impairment in ventricular filling that normally produces the Y descent. Anywho, You might remember from Sketchy Path that when it comes to cardiac tamponade, another frequently tested exam finding is pulsus paradoxus. Pulsus paradoxus is characterized by a decrease in systolic blood pressure by more than 10 millimeters of mercury during inspiration. Hence, this BP cuff in the shape of a 10 being held by our stage diver. Inspiration, represented by this bouncer holding his breath in, increases venous return to the right side of the heart. Normally, that would be just fine and the right ventricle would expand to accommodate the extra volume, but in cardiac tamponade, there's nowhere to expand. As a result, the right ventricle bulges into the left ventricle, decreasing filling of the left ventricle and leading to decreased stroke volume, cardiac output, and blood pressure. In the most severe case, your patient with cardiac tamponade may present an obstructive shock, represented by a recurring sketchy symbol, the lightning shield guitar. So medievally metal. In addition to tachycardia and hypotension, obstructive shock will also produce signs like tachypnea, cool extremities, decreased urine output, and altered mental status. Check out our dedicated shock sketches later on in this unit for more details on the clinical presentation of obstructive and other types of shock. Whereas cardiac tamponade presents with a number of unique exam findings, many of the tools we use to diagnose it remain the same. The ECG, as in pericardial effusion, can also show electrical alternance and decreased QRS voltage. The chest X-ray will be the same as well. Clear lungs with either a normal cardiac silhouette when fluid accumulation is rapid, or the classic water bottle silhouette if the effusion is large and developed more slowly. A transthoracic echocardiogram is, again, the diagnostic test of choice. Sensing a pattern here? This time, in addition to looking for a pericardial effusion, you should also see signs of cardiac dysfunction, such as chamber collapse or abnormal respiratory variation in volumes and flows. One additional test that you might rarely perform in a patient with cardiac tamponade is a cardiac catheterization. On cardiac cath, represented by a recurring symbol, the string leading into the heart, the pathognomonic finding in cardiac tamponade is that every chamber will have the same elevated diastolic pressure, a phenomenon known as equalization of diastolic pressures. Hence the equal sign sewn into the heart design on this fan's shirt. If you notice on cardiac cath that the diastolic pressure in the right atrium is the same as that in the left ventricle, cardiac tamponade should be very high up on your differential. Speaking of the differential, what else should you be thinking when you're suspecting cardiac tamponade? Well, first of all, you probably shouldn't waste too much time thinking, since cardiac tamponade is kind of a medical emergency. That said, other causes of obstructive shock should also be on your differential if you see a patient presenting in cold, that is, non distributive, shock and clear lungs on chest x ray. This includes conditions like pulmonary embolism, severe pulmonary hypertension, and tension pneumothorax. Fortunately, the chest x-ray can readily identify a tension pneumo and distinguish it from cardiac tamponade. The cardiac cath results can differentiate between tamponade, which is characterized by equalization of diastolic pressures across all four chambers, and pulmonary conditions like PE and pulmonary hypertension, in which right-sided pressures will be abnormally elevated while left-sided pressures will be abnormally low. If all this talk about pressures has your blood pressure skyrocketing, check out our series on shock for all the details you'll need to know. Let's summarize the classic patient with cardiac tamponade in a sample assessment. Darth Metal is a 48-year-old man presenting with progressive dyspnea and chest pain over the past 3 days. He has had one episode of syncope during this time as well. He has no past medical history other than a respiratory infection that resolved 2 weeks ago. Vitals on admission are significant for a blood pressure of 88/65 and heart rate of 130. On exam, he's tachypneic with cool extremities. Neck veins are distended. ECG is significant for electrical alternans and low voltages diffusely. Chest x-ray is unremarkable. Given these findings, I believe Mr. Metal is in obstructive shock, most likely secondary to cardiac tamponade. Like we mentioned earlier, cardiac tamponade is a medical emergency. So, what are you waiting for? Stab him in the heart. No, really. The definitive treatment for cardiac tamponade is emergent pericardiocentesis, or catheter drainage of that pericardial fluid. As soon as you get some of that fluid off, the patient's blood pressure should improve and they'll start feeling better. The exception to that rule is if you suspect that your patient has tamponade due to hemopericardium. When tamponade is secondary to bleeding into the pericardium, open surgical repair, represented by this rocker stepping straight into that guitar case, is needed to stop the bleeding. Notice how that guitar case looks kind of like a scalpel? Remember, kids, don't delay surgery to perform pericardiocentesis. That's how you stay metal. That about does it for pericardial effusion and its complications. Let's wrap up our review of pericardial diseases with one last uncommon disease, constrictive pericarditis. Whoa, now, Can't run away even if you want to, huh? That's what you get for being a good looking guy at a metal concert. Just look at that hair. Anyways, see how his apron is constricting his movement? That's representative of constrictive pericarditis, in which scarring and loss of the normal elasticity of the pericardium leads to constriction of the heart. Early diastolic filling of the ventricles is normal in constrictive pericarditis. However, once the heart reaches the stretching capacity of the scarred pericardium, it's like the blood hits a brick wall, restricting diastolic filling earlier than normal. This is in contrast to the pathophysiology behind cardiac tamponade, in which ventricular filling is impeded throughout diastole. Naturally, patients with constrictive pericarditis most commonly present with symptoms of heart failure. See how this unfortunate waiter is stepping on the right side of our recurring sketchy floppy heart balloon? Since impaired cardiac filling is the underlying pathophysiology behind constrictive pericarditis, the symptoms experienced by the patient tend to be those of right sided heart failure. These include peripheral edema, represented by those wide, floppy pant legs, so not metal, and abdominal distension from ascites, represented by the waiter's bulging belly. In addition, impaired diastolic filling in constrictive pericarditis means that the heart can't exactly ramp up cardiac output in response to exertion. As a result, patients will often complain of exertional dyspnea, represented by that puff of air the waiter's blowing out. Look, girl, it's not because he thinks you're hot. Let him go. So, since constrictive pericarditis is so rare, what historical factors should you be looking for to clue you into the diagnosis? Fortunately, the most common causes of constrictive pericarditis are also the most common causes of acute pericarditis. That's because constrictive pericarditis is often a chronic sequela of acute pericarditis. Therefore, we've drawn in our recurring sketchy symbol for acute pericarditis, the red-lined guitar case, to remind you to ask about a history of acute pericarditis. This includes asking about the common causes of acute pericarditis that we discussed in part 1. In addition to those causes, a few other conditions tend to cause constrictive pericarditis disproportionately. These include a history of radiation therapy to the chest, often for Hodgkin disease or breast cancer, in which high doses of radiation are delivered in close proximity to the pericardium. Hence our recurring sketchy symbol, the radiation symbol spotlight. Another cause that's often asked about on the exam is TB, represented by our recurring sketchy symbol, the cavitary cacti. When TB causes acute pericarditis, an admittedly rare phenomenon even in endemic areas, it frequently tends to evolve into constrictive pericarditis. Lastly, don't forget about heart surgery. Prior cardiac surgery is a commonly identified cause of constrictive pericarditis, hence this dirty scalpel resting on that heart-shaped plate. Constrictive pericarditis is a rare disease, so you'll definitely need to have it on your differential in order to pick it up. That said, there are a few characteristic findings that can point you in the right direction. First, as you'd expect, patients will exhibit signs of right-sided heart failure, including elevated JVP, represented by our recurring sketchy symbol, the elevated blue JVP jug. Yikes, watch out. That drink's coming out of your paycheck, girl. Let that falling Y-shaped martini glass remind you that in contrast to cardiac tamponade, the JVP waveform in constrictive pericarditis will demonstrate a prominent Y descent, reflecting the rapid early diastolic filling that remains preserved in constrictive pericarditis. Cookies. So metal? Anyway, one classic finding in right-sided heart failure is Kussmaul sign, in which the JVP doesn't decrease or even increases with inspiration. Hence this fan taking in a huge whiff of those recurring Kussmaul cookies sitting in that big blue jar. What? Haven't you heard? Cookies are so metal. In constrictive pericarditis, Kussmaul sign occurs because the stiff pericardium is unable to expand and accept that increased venous return during inspiration. All that blood has to go somewhere, so it backs up into the jugular veins, leading to an increase, or at least a lack of a decrease, in the JVP. Okay, JVP aside, there are other exam findings to look for in patients with constrictive pericarditis. As we mentioned earlier, signs of fluid overload, such as ascites and peripheral edema, are frequently seen in patients with constrictive pericarditis. On physical exam, one way to distinguish between hepatic and cardiac causes of volume overload is the hepatojugular reflex test. Just like this moshing metal fan, the hepatojugular reflex test is performed by compressing the liver for a sustained period of 10 to 15 seconds. If the JVP remains elevated throughout the test, your patient has a positive hepatojugular reflux and is more likely to have right-sided heart failure. What did I tell you, Braden, you punk? Moshing is so not metal. During your cardiac exam, listen closely to those heart sounds. If your patient has constrictive pericarditis, you may hear a pericardial knock, an extra heart sound occurring slightly earlier than an S3 that reflects the abrupt end of diastolic filling as the heart reaches the stiffened pericardium. Like its name suggests, the pericardial knock kinda sounds like someone banging on the heart wall, much like this metal lady banging on the table. Hey, you can't have your hot waiter and your martini too, lady. While these physical exam findings should definitely pique your interest in looking for constrictive pericarditis, most of them are not very specific. It's the imaging findings that'll nail the diagnosis for you. On chest x ray, you might see calcification of the pericardium, represented by the white stitching lining this guitar case, which is highly specific for constrictive pericarditis. It's important to note, however, that the majority of patients with constrictive pericarditis will not have pericardial calcification. As with all other forms of pericardial disease, the echo is the diagnostic test of choice for constrictive pericarditis. On the echo, look for pericardial thickening and abrupt impairment of ventricular filling during diastole, represented by this newbie bartender struggling to fill those glasses with water. Now, because constrictive pericarditis is pretty rare, you should have plenty of diseases on your differential when a patient presents with primarily right sided heart failure symptoms. Fortunately, the other causes of right sided heart failure are pretty easy to identify with a detailed history. An elevated BNP can also help distinguish other causes of heart failure from constrictive pericarditis, since wall stretch is minimized by the thickened pericardium. Of course, since echocardiography is the diagnostic tool of choice for heart failure in general, it too will help you nail the right diagnosis. Don't forget about cardiac tamponade. Yup, we're bringing back this very sketch you're watching. So metal. Since cardiac tamponade most frequently results in obstructive shock, hypotension would be a big red flag that you're dealing with tamponade rather than constrictive pericarditis. And, of course, the echo will show a pericardial effusion in cardiac tamponade, definitely pointing you towards tamponade and away from constrictive pericarditis. All right, let's summarize the clinical presentation of constrictive pericarditis in a sample assessment statement. Cobra Kai is a 46-year-old man presenting with exertional dyspnea, fatigue, and leg swelling that have slowly worsened over the past 3 months. He immigrated from Myanmar 6 months ago and has not seen a physician since moving to the US. He has no stated past medical history and takes no medications. Physical exam is significant for elevated JVP, Kussmaul sign, and positive hepatojugular reflux. Chest x-ray is significant for pericardial calcification. Given these findings, Mr. Kai's symptoms are most likely due to constrictive pericarditis from a previous TB infection. Diagnose constrictive pericarditis in your patient? Pat yourself on the back and rock out for a hot minute. Okay, that's enough. Now, let's figure out what we can do about it. First things first. If the underlying etiology is treatable, such as ongoing TB, uremia, or connective tissue disease, you should definitely get on that. That said, pericardiotomy, represented by our recurring sketchy surgery scalpel, is the only definitive treatment option for patients with chronic constrictive pericarditis. Fortunately, the majority of patients have significant improvement in their symptoms following pericardiotomy. Whew, I can't take much more of this amazing music. Before we get out of here, let's briefly recap what we've learned. Starting with pericardial effusion. Most patients with it are asymptomatic, but it kind of depends on the speed with which fluid accumulates in the pericardium. Acute effusions will almost always cause symptoms since the pericardium doesn't have time to stretch to accommodate the buildup of fluid. The causes of pericardial effusion are very similar to those of other pericardial diseases, including acute pericarditis, malignancy, cardiac surgery, and other trauma to the chest. The hallmark of a pericardial effusion on exam is a combination of muffled heart sounds and absent PMI, both resulting from the cushiony effect of that pericardial fluid. This is also reflected in the ECG, which may show electrical alternans and low QRS voltages. Definitive diagnosis of a pericardial effusion is made on echo, where the effusion can be visualized and hemodynamic effects on the heart can be identified. Speaking of hemodynamic effects, the most well-known complication of pericardial effusion is cardiac tamponade. Tamponade most commonly presents with symptoms of acutely progressive dyspnea and chest discomfort, although patients can also present in frank obstructive shock. On exam, hypotension, elevated JVP, and muffled heart sounds can all be seen. In fact, these 3 classic signs form Beck's triad. Don't expect to see the entire triad in every patient, though. Two relatively unique findings in cardiac tamponade include absent Y descent on the JVP waveform and pulsus paradoxus. As with pericardial effusion, definitive diagnosis of cardiac tamponade is made on echo. However, some patients may undergo cardiac catheterization. If they do, the pathognomonic finding of cardiac tamponade is equalization of diastolic pressures among all four chambers of the heart. If you diagnose cardiac tamponade, move immediately to pericardiocentesis to pull off that fluid and rescue the patient. Finally, constrictive pericarditis is a rare condition that most commonly presents with symptoms and signs of right-sided heart failure. A couple of unique causes of constrictive pericarditis tend to be commonly tested: mediastinal radiation, TB, and cardiac surgery. On exam, look for Kussmaul sign, a specific finding in right-sided heart failure in which the JVP fails to decrease or even increases on inspiration. In contrast to cardiac tamponade, constrictive pericarditis will produce a prominent Y descent due to the abrupt halting of ventricular filling earlier in diastole than normal. A pericardial knock is pretty specific for constrictive pericarditis, but it can be difficult to tell apart from a regular old S3 gallop. Imaging, though, is where the diagnosis of constrictive pericarditis is really made. If you're lucky, you may see pericardial calcification on chest x-ray, but it's pretty rare. Ultimately, as with all pericardial diseases, definitive diagnosis of constrictive pericarditis is made on echo. Once the diagnosis is made, the only definitive therapeutic option for constrictive pericarditis is surgical pericardiotomy. So do it. Do it now! Hear that? You're all done with pericardial diseases. Let's blow this pizza palace before the crowd realizes you're not going to do an encore. We'll see you at the bar for the after party. Don't be late.